Everyone, and welcome to this scientific event on celebration of the International Pathology Day 2024. Here from Sheffield Orman Hospital Histopathology Department welcomes all of you for attending this scientific event on Sunday, 15th of December 2024, virtual event through Microsoft Teams platform. Our first case today is a presentation by Dr. Nada Al-Garhi, Assistant Lecturer of Pathology at Faculty of Medicine, Suez Canal University, and it's entitled A Wolf in Sheep's Clothing, the Unexpected Malignancy of Fibrous Dysplasia. The case is under supervision of Professor Dr. Shadi Elia Anis, Professor of Pathology at Faculty of Medicine, Cairo University, and Dr. May Suleiman, Lecturer of Pathology at Faculty of Medicine, Cairo University.
Good morning, everyone. This is Nada Al-Garhi, a lecturer assistant of pathology in Suez Canal University. Today, I'm going to present A Wolf in Sheep's Clothing, the Unexpected Malignancy of Fibrous Dysplasia. First and foremost, I'd like to thank Sheffield Orman for hosting this conference every year for us to have the opportunity to learn and know new cases and share the knowledge. This presentation is under the supervision of Professor Shadi Elia, Faculty of Medicine, Cairo University, and Dr. May Suleiman, Lecturer of Pathology, Faculty of Medicine, Cairo University. Today we're having a patient, 21 years old, male patient, presented with infratemporal tumor involving the face and the skull. This CT is showing us multiple nodularities on the calvarial bone, showing a protrusion. And the radiology comment was extensive expansile bony lesion with abnormal mineralization of mixed lyric sclerotic components as seen in this coronal section, with abnormal bony remodeling seen involving the calvarial bone at the right side of the skull base, orbital walls, mandible, and alveolar margin. So the comment is polyostotic fibrous dysplasia to be considered. But as we see a closer look on a different plane of the CT, we can appreciate the polyostotic fibrous dysplasia, but if we go closer to the sinuses, we start to see another mass that the radiology says another finding, a rather defined mass, infiltrative borders involving the maxillary sinus measuring 70 by 65 by 55 millimeters, with medial extension to ethmoidal air cells, nasal cavity, cranial extension to orbit, caudal involvement to alveolar margin and heart palate, extends posteriorly to nasopharynx, parapharynx, and lateral extension to temporal fossa. So the growth pattern is consistent with invasive growth of malignant clisteria. And this is another section, a coronal one, that shows the well-defined but with infiltrative borders mass involving the maxillary sinus and the orbit and laterally into the bone, medially, inferiorly, and superiorly. And so the wolf we received was multiple gray-brown fragments, and here is the H&E. It's formed of spindle cells arranged in short fascicles with focal swirling pattern. And when we zoom in, we see markedly pleomorphic spindle cells with eosinophilic cytoplasm and high nucleocytoplasmic ratio and prominent nucleoli. Some vessels are compressed, some giant cells, multinucleated giant cells. Necrosis is seen as well. This could be rather osteoid deposition. Mitotic figures are seen, atypical ones too, and mixed with many osteoclast type giant cells arranged in sheets as seen here. And this is a mitotic figure, and this one. Necrosis is about 5%. compressed vessels and scattered staghorn vessels. This is a compressed vessel. And these are the staghorn vessels. Here as well, and the osteoclast giant type cells. Mitotic activity was high, 13 per 10 high power fields. And there were portions of reactive woven bone. And so the final diagnosis based on H&E was infratemporal mass biopsy, undifferentiated osteoclast-rich sarcoma grade 2. And in view of the attached radiological reports, this tumor represents sarcomatous neoplasm secondary to polyostotic fibrous dysplasia, and immunophenotyping is advisable. The question becomes, what is the relation between fibrous dysplasia and sarcomatous transformation? Is this something that we commonly see in practice, or is it something rare that we shouldn't think about? So, fibrous dysplasia is a benign fibrosis lesion that may involve one monostotic or multiple, and then it's called polyostotic bones. It's a developmental disorder, and it's a gain-of-function mutation in GNAS gene, leads to increased downstream adenyl cyclase activity, and sarcomatous transformation is rather very rare. Some papers claim it's less than 1%, other papers around 2.5%. A recent paper that was published 2024 November with the title Malignant Transformation of Craniofacial Fibrous Dysplasia, a Clinical Pathological Immunohistochemical and Molecular Analysis of 15 cases in one single institution. They did a comprehensive literature review, or they studied 15 cases with malignant transformation, and they saw that 80% of the cases in the literature of fibrous dysplasia turning into a sarcoma were diagnosed as osteosarcoma. Chondrosarcoma were around 6%, and high-grade sarcoma of uncertain differentiation were around 13%. Another paper that's titled Malignant Transformation of Craniofacial Fibrous Dysplasia, it's a systemic review of overall survival, showed that 45 patients had developed sarcomatous transformation, and of these 45 patients, 29 of them turned into an osteosarcoma, 7 patients turned into fibrosarcoma, and 6 patients turned into a chondrosarcoma. 3 patients turned osteoblastic osteosarcoma. So, when to suspect sarcomatous transformation? It's really inconclusive, and multiple papers questioned and researched an answer for this question, but they were non-concordant. 2 papers claimed that it's more common in polyostotic forms and syndromic patients, McCune-Albright syndrome and Musser-Brout syndrome. Another paper claimed that it's really doesn't correlate with age, type, or history of radiation, do not influence the transformation of fibrous dysplasia into sarcoma. So the conclusion is, suspect transformation when the patient starts to complain of something new, any abrupt, rapid, or new pain or swelling, any visual or hearing deficit should raise the possibility and alert the clinician for possible sarcomatous change. With this knowledge in mind, we ordered immunohistochemistry to confirm or deconfirm the lineage of the sarcoma and exclude other possible tumors. And so the differential diagnosis in our case with the spindle cell proliferation and giant cells was either fibrosarcoma or osteosarcoma. And we also wanted to exclude the possibility of squamous cell carcinoma or maybe a tumor of a neural origin. And so we ordered P63, which was rather weakly or maybe even negative, and it took really focally in the tumor cells. SAB-B2, on the other hand, was diffusely positive, and of note, we should state that fibrous dysplasia is positive for SAB-B2, so the positivity of SAB-B2 alone is not conclusive of osteosarcoma, rather the anaplastic features of the tumor itself, and the Ki67, which we will see, is the confirmatory immunohistochemistry and the confirmatory H&E features that will help us diagnose, not the SADB2 alone. Here is another picture of the diffuse strong positivity of SADB2. Another one. And we ordered S100 to exclude the neural origin of the tumor, and it was not really strong expressed. And the Ki67 as seen here is more than 50%, is expressed in more than 50% of the tumor tissue. This is a good one. And so our final diagnosis is few tumor cells are positive for P63, tumor cells are diffusely strongly positive for SADB2, tumor cells are negative for Desmin, 50% of tumor cells are positive for Ki67, and findings are compatible with secondary osteosarcoma.